Good evening, everyone, and welcome back to the Southwest London Training and Development Programme. For those of you who have joined us before, welcome back. And for those of you who are joining us for the first time, this is a brilliant way for all of us to come together as first contact practitioners, GPs, primary care practitioners, MSK practitioners, to be able to strengthen the referral pathways for our patients and to help improve our patient journey from primary care through to secondary care. We will be recording the webinar, so not to worry to record this yourselves, and we will share the video with you afterwards. So this evening, I'd like to introduce Mr. Paul Hamilton, who will be talking to us about foot and ankle conditions. He'll be talking about bunions, Achilles tendinopathy, I can't remember what the third one is, but I'm sure he'll fill you guys in. He is a consultant orthopaedic surgeon working at Epsom and St. Helier and the Southwest London Elective Orthopaedic Centre, specialising in foot and ankle conditions. So over to you, Mr. Hamilton.
Hi all, thanks for coming on. Fully appreciate your time of what is a sunny evening. So, and thanks, Budine, thanks for going through that. The other thing I'm going to talk about is ankle sprains. Just hold on one second while I just go into that. Right, great. So I'm Paul Hamilton. I specialise in foot and ankle surgery, which is a joy. It's fantastically interesting and covers a variety of different things. But today I'm going to go into bunions, into Achilles problems and ankle sprain. There's quite a lot of information that is available here, but I'm going to try and skip over some of the things so we don't take up too much of your time. So just to pass on, foot and ankle, I think, is quite a difficult subject. It's interesting for those that specialise in it, but it can be quite difficult to make a diagnosis sometimes. It's something I think we all at medical school looked at and thought, yeah, it's too complex, but it's a fascinating field. And just to go through what I think my role is, and at any point, if you feel as though you need to make a referral because you're not sure what's going on, we'll take any referrals at all, because I think it can be quite difficult and it can be quite difficult to understand. So my role really is to make a diagnosis, to give the appropriate investigation, to hopefully give a prognosis and select the appropriate treatment. And actually, interesting, of all the surgical specialties, we only go on to surgery in the minority of cases. So conversion rate's pretty low, at probably around 3 in 10. And we're very happy to see all the other patients because I think, I think it's a reasonably complex subject. Just a plea, if that's all right. If you're going to do investigations in the community, if you're going to go down the route of x-rays, this is really the protocol you should go for. So if you're going to do foot x-rays, we really need weight-bearing APs, weight-bearing laterals of the whole foot, and an oblique, which is non-weight bearing. And going on from ankles, we also need a weight-bearing AP, a weight-bearing lateral, including the whole foot, and an oblique of the foot. And I mean, the key to that is if you do non-weight bearing x-rays and then refer them up, we're just going to repeat them. So, and I've got no problems you not doing any x-rays at all, because we can do them as they arrive and it doesn't slow down an appointment at all. So if you want to investigate in the community, that's absolutely fine. But if you feel it's difficult to get weight bearing ones, the local department don't want to do it, then that's also okay. And we can then do that when they come up and see us. Please only order MRI scans if it's appropriate and you know what you're really looking for, and the same with ultrasound scans. So I'm going to talk about Achilles tendinopathy first. I'm going to go through the types, 2 main types, a little bit of how to make the diagnosis, some of the causes, and a little bit about the pathology, because that gives you an indication as to how we can treat it, and then the appropriate investigations. So usually people present with pain in their Achilles. It's worse first thing in the morning. They can be associated with swelling and some stiffness. It's usually worse at the end of the day. And it's often activity related at the beginning, but it can affect them all the time. It can even affect them at night. Just a slight word of warning from the Achilles point of view. If someone presents having heard a pop, or they feel as though they've been kicked to the back of the leg, then the diagnosis is most likely to be a rupture and they need immediate treatment. They may actually, a lot of them do walk straight away afterwards, and so that's not diagnostic. They may not be able to push off as well, but actually they carry on walking. They can't play the activity they've been doing, but if they feel a pop, though, feel as they've been kicked to the back of the knee, they need urgent investigation. And this is just an example of how to investigate if you ever see them. And it's basically a Simmons test, which is squeezing the calf, and if the heel doesn't move, then the calf isn't attached to the heel. And you can usually feel a gap if it's immediate, but if it's a few days down the line, you can't feel a gap because it's filled with hematoma. So if you squeeze the calf and the heel doesn't move, so basically the calf isn't attached to the heel, then be concerned for rupture, and they need to be sent up to A&E. Just of interest, we've set up, actually, quite excitingly for me anyway, an Achilles tendon working group, Achilles tendon rupture working group, which has been across all the Southwest London hospitals. And it's pretty difficult to get a protocol in place for 4 different hospitals and 9 different surgeons to do the same thing, because we all think we know best. But we've now, and we've just developed this, a rehab protocol, a patient-centered shared decision-making, an agreed treatment from A&E, and a post-decision treatment protocol as well. And this is all going to be outcomed as well. So this is actually, for me, extremely exciting, and I've been leading on this, and hopefully we'll get this all out very soon. But I mean, we've had, amazingly, out of lockdown, we've had 14 Achilles ruptures in the last couple of weeks, which is literally unheard of. The youngest being 19, and people just back doing things, mostly playing football and rupturing Achilles. So we're absolutely inundated at the moment. So going back to the 2 different types of tendinopathy, there's 2 main types. There's the non-insertional Achilles tendinopathy and the insertional Achilles tendinopathy. And so again, very simply, the non-insertional is just not where it inserts. And I hope you can see my arrow, but there's an MRI here which just shows a very swollen Achilles. And it's basically a little bit away from where it inserts, and it's non-insertional. It's the Achilles, and it's degeneration within the Achilles. And the other one is insertion of Achilles tendinopathy. And again, it's where the Achilles inserts, it's the Achilles, and it's degeneration within the Achilles. It's not really an itis, it's not really an inflammation. I'll mention that a little bit later. So looking at the causes of it, you don't necessarily always need to know this, but I think it's quite interesting when you understand what the treatments are. They're the intrinsic factors, so problems with the tendon or the mechanics around the foot, or just basically simply the anatomy. And they're then the intrinsic factors, which is usually a change in load for some reason. So intrinsic factors, so basically all that means is that one of the issues can be an abnormal tendon. So why has someone got an abnormal tendon? Well, with age, your tendon reduces in strength and size. Any form of inflammatory arthropathy can cause it. Gout, systemic corticosteroids, hyperlipidemia, interestingly, sarcoid, and actually ciprofloxacin is well known for causing issues, especially ruptures, actually. So it's something actually to warn people about. Certainly long-term ciprofloxacin can cause a real issue. And also obesity, men with a diabetic, hypertensive, and the oral contraceptive pill, hypertension, and the HRT are also associated. So they're the main things that can cause a problem with the tendon. Other mechanical problems are more around whether there's a stiff subtalar joint. So the subtalar joint causes inversion, eversion, just the movement underneath the ankle. And if that's stiff, that can cause Achilles problems. If you look at the 2 pictures below, there is a foot which is normal, actually, which is the one on the left with the arrow. So your foot, when you stand and look at it from behind, you should drift off a little bit to the side, and that's called valgus, which is actually normal. But the one on the other side is when it's usually seen in people with a high arch, and that's invarus, and that changes the load distribution across the Achilles, and is also associated. And the one that I find most common is a very tight calf. So people with an extremely tight calf, it loads abnormally. You get increased load, increased stress through the Achilles, and I think that certainly is associated, and something we can concentrate on in terms of treatment. And then finally, there's some people have different anatomies. So just down here, you can see this massive bit of bone here, which is a Hagland deformity, which is just it's often not an extra bit of bone. It's just a prominence of bone that can cause irritation. That can be associated with insertional Achilles tendinopathy. And a high arch can also basically make that bone protrude more, and is also thought to contribute. And finally, your extrinsic factors, which is often something we can do about, and something that needs immediate looking into. So increased load through the Achilles, either increased intensity of training or failure to condition. So all those people that rupture their Achilles have basically gone from nothing to loads, and that's why it's ruptured. But they could well have developed a tendinopathy because they're basically loading through a tendon that's not used to that load. Obviously, running on hard ground increases the load. Poor shoe wear, whether it puts them into a slight degree of inversion, eversion, varus valgus, and even if the shoe wear is very tight and causing rubbing on the back, that can also be associated mainly with insertional Achilles tendinopathy. Now, this is a little bit of well, this is a stress strain curve, and this just understands basically whenever you use your Achilles, it stretches to a degree. And that's the load through it causes a strain. And when you're running, you cause enough of a strain to cause these little microscopic failures. So they're nothing you would ever notice. They don't often cause pain, but the normal hemostatic mechanism is that you get injury repair, and it goes around in a cycle. Obviously, if you put a lot of pressure through it, a lot of load through it, it can then rupture. And this graph can shift to the right or left depending on whether you condition your Achilles or whether you have a deconditioned Achilles or you have one of those other problems that causes abnormality within the Achilles. So what really happens normally is you get the load through it, you get these small little micro tears, and you heal normally, and everything's back to normal and you don't notice anything. But if you carry on loading and don't allow the healing process, then that can go on to further micro tears, and obviously that leaves you with a more abnormal Achilles. And then you go on to what's called neurogenic inflammation. You get these new blood vessels that form at the front of the Achilles. With that comes nerves, and this causes the Achilles basically to become degenerate. So it's not really a prostaglandin-mediated inflammation. So you don't see, if you take biopsies, you don't see much inflammation going on there. What you do see, and this is a snowstorm, which is actually an ultrasound, which you see in Achilles here, and all this red is not meant to be there. So that's pathological neovascularization. So new blood vessels come into the front of the Achilles, and that causes some nerves to, brings in nerves with it, and that's what we think causes the pain, and that we term as neurogenic inflammation. So treatments, with everything, if you take away the causes, you'll get better. So you've got to guide your treatment to that, and then you've got to start rehabilitation. So removing aggravating factors, try to reduce the load through it, make sure there's no malalignment, shoe wear fits well, training regime is correct, all those kind of things. You can then look at how to other ways of trying to treat the load. You can then go to try and get some healing through the Achilles. And that's done by promoting inflammation, and that's what basically surgery does. Or you can try and treat that neovascularization, which I say is pathological around the Achilles. And then with all this, you've got to then rehabilitate the tendon so it doesn't come back. So different treatments, rest doesn't immobilize, rest works, but immobilization doesn't work. So we don't put them in cast or boots. So I don't treat anyone like that. I think it just deconditions the tendon more, and you're left in a worse situation. However, you can modify the activities, reduce running, reduce load through it, and certainly that's the first stage. Non-steroidals don't really seem to work because it's not really an inflammation. Orthotics can be very helpful, and something can be provided in the community. If they're in varus or valgus deformity, then that will help with the load. A heel raise can offload it for a short period of time, and just doing something that takes a bit of the repetitive impact away, so simple cushion trainers. Physiotherapy is the gold standard, clearly, and however you do it, through the alpha-Friedson eccentric stretching or heavy slow resistance, that's for the physiotherapist to really choose. But yeah, it's the gold standard of treatment, definitely. Night splinting is not really shown to work. Ultrasound therapy hasn't really been shown, but I don't mind it being used. Deep friction massage, again, has not really been shown, but again, I wouldn't fight against it if people were offering that. Shockwave therapy is something I'm sure most people have heard of. It's extracorporeal shockwave therapy. It's basically sound waves. It's like ultrasound, but a lot stronger. And it does have a direct effect and also indirect effect. And basically the way it works, the modality of treatment, is it causes an inflammation and the natural sequelae of inflammation as it goes on to heal. So again, similar to what we do in surgery, which is basically debride it, cause bleeding, and that causes inflammation that gets better. This is a non-interventional way of doing it. It's not a nothing intervention, however, and everyone that undergoes shockwave therapy, I investigate before, so I know either via ultrasounds or MRIs, so I know exactly what I'm dealing with. So I've got the diagnosis correct. I confirmed it on imaging before we go down the route of what is non-interventional but can have complications, although very rare. You can try and strip off that new blood vessel that comes in front of the Achilles, so that's the tibial side of the Achilles, and we can do that via lots of different things. The one I use is a high volume injection, and basically it strips off those nerves and those vessels, which we described as pathological, and that again can be curative. And then we can look at a different modality, which is trying to take away a bit of the load, which is an Achilles tendon lengthening procedure. And what most of us in the region now are using is something called a posterior medial header gastroc release, which is a reasonably minor operation. People walk straight away afterwards. It just lengthens the Achilles, not significantly such that it defunctions it, but it lengthens it, which can take a load of it. And certainly I find that a lot of people presenting with Achilles and plantar fasciitis have very tight calves, and they have a recurring problem of one causes another, causes the next, and this is a reasonably good operation, which is pretty low risk. So what do we do at Epsom St Helier? And what can you do in the community? I'd say physiotherapy is the right way forward in the first instance. Orthotics and stretching the calf can be combined, and certainly that should be done before they come anywhere near us, I would have thought would be the right way forward. We can then provide shockwave therapy. We can do high volume injections. They can't be done at the same time. We need at least 3 months in between if we're going to do both. We can actually combine that with a calf release. And to be honest, I put the last one down as a knife to indicate surgery, but I haven't operated on Achilles for years because we just get them better. So most of this treatment is very successful. Now, I'm going to put a little caveat to that. Most of what we just described is non-insertional Achilles tendinopathy. Insertional Achilles tendinopathy, the treatments are slightly less, although interestingly enough, shockwave therapy seems to work slightly better, but there you can't really inject much around there. So there's more limited procedures available, more limited conservative management. And undoubtedly we do operate on some of those when they have massive bone spurs at the bottom, which are basically enthesiophytes, and occasionally we need to take them away and take away the hagland. So that's this is mainly, let's say, my non-surgical options, than getting them better via non-surgery is mainly through non-insertional. So we've actually, and going on from that, we've recently done an audit. I think we looked at the last 5 years of our shockwave therapy, and it gets around 80% of people better. So it's pretty successful in terms of how we do it. So in pretty much in summary, the key is getting the diagnosis right, making sure that's what the problem is, and one's insertional, one's not, and it's the Achilles that's painful. I think at least 3 months of conservative management with physiotherapy and insoles is the initial management, and that can be done through the community. If you're going to go down the route of investigation for both non-insertion and insertional, I think it is worthwhile getting x-rays, again, weight bearing. Again, we can do that if that you find that difficult to provide. For me, the next modality for non-insertional Achilles tendinopathy in terms of investigation is an ultrasound, because it can show those new blood vessels, which an MRI can't. Whereas for insertional, an MRI is better because it can show the anatomy slightly better. And obviously then treatment comes in a shared decision making. Now I'm going to stop at the Achilles. I could answer any questions about that if there are any questions, or I can move straight on to the exciting bunion. Shall I move straight on? I'll move straight on to the bunion. So in terms of the bunion, and I'll go through it, I've started off with here, which is the referral criteria for referring to us or those that need an operation. So we need to fill this out if someone's going to undergo surgical treatment. And this has obviously not come from us. So this is community-led. So conservative management is usually via toe spacer, bunion protector, shoe wear change, giving patients information. And soon we'll be able to, I think we're uploading our bunion leaflet onto the website of the EOC, which is being revamped hopefully in the next few weeks. But that's a very thorough patient information leaflet. Obviously, they've got to have a bunion before they go down the route of surgery. They have to be willing to undergo surgery, and then that means they're not going to be able to drive for 6 to 8 weeks, and actually the recovery is 3 to 6 months. They're usually able to walk straight away, but they're 6 weeks in a special shoe, and the swelling and some discomfort could go up 3 to 6 months. That's not a problem, but they just need to know that that's going to happen. And no matter how the bunion is done, that's the same recovery. Obviously, if they fail conservative management, that's a reasonable reason to go down the route of surgery, or if they have a very significant deformity causing problems. And actually, that includes second toe deformity. Now, I'll describe that in a minute, what can happen. But if the bunion, if you do get a bunion, the first toe, the first ray defunctions, and the cause of clawing in the second toe is not because the first toe underrides it, it's because there's mechanical overload around the second metatarsal. So it's around this kind of area, but I'll describe that in a minute as we go on. So bunions, this is not the same patient because we don't have the natural progression of any patient because it goes years. But on the left, you basically see a very minor bunion going on to more severe, going on to very severe, going on to ridiculous. So just so you know what a bunion is, it's not a growth of bone on the inside here. It's basically this bone, and you can see it moving across. This bone moves medially, so it moves across here, and this becomes more prominent. So the medial exostosis, which is here, becomes more prominent, and that's usually where they get their pain. But they can get pain in different areas, but that's what a bunion is, so not a growth of bone. And it's not really the big toe moving out, it's this bone moving this way, and in turn the big toe moves across. We don't operate on pain-free bunions. It's not a cosmetic procedure, and it shouldn't be undertaken as a cosmetic procedure. And the main reason being this list below. Unfortunately, bunion surgery has probably the longest list of complications out of any surgery I know. Around the success rates, and we've reviewed our data, is around 90, even up to 95%, but the risks are many. So it shouldn't be undertaken lightly. And if you operate on someone without pain, there's a possibility of leaving them pain and they don't end up happy, which is obviously what we all aim for. What's the cause? Shoes, possibly, we don't really know, but certainly they can cause some of the pain. It can be related to inflammatory arthritis, rheumatoid arthritis. It's definitely got a familial trait to it, but not in everyone. It is related to flat foot. So if you have a pes planus, a flat foot, then that mechanically causes the bunion to move out, so it pushes out. So for those, a simple arch support can be very helpful. And then ligament laxity is certainly associated, but often we don't know, and it's just people present with a bunion. So this is again the diagrams of those. This is a normal foot here. So the foot goes across here, and what you can see is the distance between the two, the first metatarsal and the second metatarsal, is getting bigger. And that's really what a bunion is that distance growing and the first metatarsal going medially and that becoming more prominent. And when that happens, these two little bones underneath the bottom, these are called sesamoid bones, they dislocate or sublux underneath. And that means that FHL, which is the flexor hallucis longus, which pulls it down, and EHL, which pulls it up, they then start to increase the deformity. So they can rapidly progress when they get over to a certain degree. Doesn't mean they all will rapidly progress, but they certainly can. So that's basically what we see. We don't really know how long it takes. I can't predict how long a bunion is going to get before it gets bad. Some people manage for many, many years. Some people it gets bad very quickly. I would say the former being more common than the latter. And if people can manage it, I'd recommend they manage it. And it may take, I mean, the most common thing we see is a patient saying, I don't want to end up like my mother who looks like this. But you do for what your symptoms are now, not what you think they are going to be in the future. Because even a foot like this may be completely pain-free and they manage it very well. And actually surgical correction of a foot like that is quite difficult. However, we do know it will progress. We just don't know how long it will take. And if it does progress, what does that really mean? Should we be doing them early? That's one of the questions I always have. Now, I've said we shouldn't be doing it on a foot that's pain-free, but they can get other problems as it does progress. And if we can do them more early, maybe we prevent some of these. So what are the other problems that a bunion can cause? Well, you get increased deformity, you get the medial exostosis becoming more prominent, but you also get point loading in the joint. So when you get to a point of this, which is a severe bunion, you will have arthritis within that joint. So bunion surgery doesn't deal with arthritis per se, so they can be left with pain even after successful surgery. So you get the single point loading and you get arthritis within the joint. This is what I was mentioning earlier, or alluding to earlier, where the bunion, the first ray doesn't work as well. So the push off doesn't work as well. And you get loading around the second toe. And this is a classical example of a callosity under the second toe. And callosity, all that is hard skin. It's the natural reaction of the bottom of the foot to increase pressure. And it tries to protect itself by putting up hard skin. And the cause of that callosity that you see, that hard skin underneath there, is secondary to the bunion. And subsequent to that, they get injury to the joint, and they get injury to the thing called plantar plate, and that causes the clawing. So the clawing per se of the second toe, and it can go on to the callosities can go on to second, third, fourth, is all secondary to the hallux valgus. So if they've got hard skin underneath there, the deformity, it's a bunion that's causing the problem. So you can also get midfoot problems. This patient here, we used in the middle of the foot there, has got a stress fracture which is healed there, and that's due to increased loading here. This patient here has got arthritis around the second TMTJ, and I'm sure that relates to increased load through here. There's not much you can do about it, but it's there. And if people with, especially with ligament laxity, with a very flat foot, or we don't know which comes first, does the flat foot come first, or does the bunion come first? So certainly people with a significant flat foot can then go on to develop a bunion, and vice versa. People with a bunion can then go on to develop a flat foot, we think, but that may take many years. So what are your treatments? I wish there was prevention. If anyone does know anything that can prevent, let me know. But the treatments are buy shoes that fit, wider toe box, stretching of toe leather, bunion protectors, toe spacers. They can all be very helpful and can manage people for many years. It then, I'm afraid, jumps straight to surgery. And the most common surgical procedure that we perform is this thing called a scarf osteotomy, which is, I say, most of the UK consultants now do this, most of the foot and ankle consultants anyway. And we've nicked it from joinery, which is a very stable joint. And you can see this here, that's being used there. And we just basically do that in the foot. And you can see the exact same joint has been moved across here. So basically we take this, the bunion would be on this side here. We shift the bone across. We get those two little bones, the sesamoid bones, to sit directly on the metatarsal head that refunctions the first ray, gets rid of the pain, and that's successful in around 90% of cases. And this is just some clinical examples of someone with a bunion. You can see the widening here. This is the same one as earlier. So they've had a stress fracture here. There's widening here. Actually, this radiologically doesn't look as bad as some, but you can see there's a big soft tissue lump around the medial side. And what we've done is we've broken that across, held it with a screw. And the screw is the reason why this isn't as painful as it used to be, because we fix it, it's rigidly fixed. Years ago, when everyone said bunion surgery was enormously painful, we didn't fix it with anything. So I'm not surprised it was painful, because we were breaking it and leaving it. But now we fix it with a screw. And actually, although the first few days can be painful, it's not as bad as it used to be. Although obviously I've never had it. But and there's the other thing we've done is an Aiken just straightens out the toe. So that's a successful bunion. This is, again, a more severe bunion. You can see that's very severe, very prominent. And we've done exactly the same. We've shifted it across, and that looks excellent. So that's kind of what we're aiming for, the goal of what we're aiming for. But when we make a decision with surgery, we have to go through everything. This is a great book, by the way. Atul Grandi does some great stuff, and this is all about complications. But anyway, the list of complications is massive. So we do really have to, it is shared decision making with the patient. They have to understand what it's all about, and they have to realize the recovery and outcomes, because an unhappy patient is one that doesn't understand. And the 3 to 6 month recovery is more to be reassuring than anything else, because that's the reality to it. Pretty much all the surgery I do has that recovery. And actually, that doesn't mean they're not going to be good after 6 weeks. They're not going to be able to do things after 6 weeks. They definitely can't run till 3 months, but it just means they won't be right for that length of time. And if you tell them that, they'll understand. And they're usually pretty happy with that. So obviously, it can go on from very minor going on to very major. And I certainly think we should be doing it before it gets to that very angry face, because that requires different surgery, which is very complex. So again, going back to the criteria in summary, they need to have gone through conservative management. they need to go through simple things: shoe wear, chain, bunion protectors, toe spacers. It's all very simple things. Most people have done it, to be honest, but if they haven't, they should do. They need some patient information to understand what it's about, and if they obviously would need the indication of having a bunion. And if they are being referred up, they need to really be willing to consider surgery. Now, all because they've come up doesn't mean they will have surgery. They need to talk it through clearly, but they need to consider it as an option. Because otherwise I'm not sure what we're seeing them for, other than a diagnosis if you're struggling. And obviously failure of conservative management is another. And then severe deformities or secondary deformities are the main criteria for referral. If you're going to do x-rays, again, weight-bearing x-rays, they just get repeated if they're not weight-bearing. And the other little plead is, please organise ultrasound scans only if you really know the diagnosis and what you're keen on. If someone's got clawing of the second toe with a callosity underneath, there's no point doing an ultrasound scan because it's not going to be a neuroma. This is a mechanical overload, and any callosity or deformity is not going to be neuroma-led. It'll be mechanical overload and disruption of the joint. That's everything for bunions. I'll move on unless there's anything that anyone wants to particularly ask. No, wonderful. So going into ankle sprain, what I'm going to go through roughly is, first of all, making sure that we know that it is a sprain, when to investigate acutely, because I don't think I can talk just about ankle sprain and just talk about the long-term recovery. So when to investigate acutely and refer acutely, a little bit about high ankle sprains because you don't want to miss them. And then I'm going to go into why they haven't got better. So some don't get better, an amazing amount don't get better, some of the treatment options, and then a little bit about ankle instability. So is it a simple ankle sprain? An ankle sprain is inversion. So they invert their foot. So they go over on their foot, the sole of their foot points towards the other one. And that's classically the mechanism of injury for ankle sprain. If it's something else, so it everts the other way, it's unlikely to be just a simple ankle sprain. So inversion injury, they are tender where that thumb is. That's where the ligament's usually ruptured. ATFL, if you get them very quickly, they're only tender there. When the swelling gets a bit more diffuse, it can be a bit more difficult. But actually, the ATFL, the anterior talofibular ligament, is the one that's injured most. You can injure CFL. PTFL on the back is very, very rarely injured. But actually, ATFL is the most common in its pain just there. Classification, orthopedic classification, always goes 1, 2, 3. And basically, you can look at the swelling and the tenderness and their loss of function. So if they've really lost function, they're struggling weight bearing, they've got a significant amount of swelling, and they've got significant pain, they're probably in the higher grade of ankle sprains. And that can affect treatment and certainly can affect recovery. You know, grade 1 sprains get better in 48 hours. Grade 3 can take months. A little bit about prognosis post ankle sprain. I always find this very interesting in the fact that, you know, a third of them may still have pain at a year, and up to a quarter of them have pain at 3 years, which is really quite amazing considering, you know, pretty much everyone sprained their ankle. Mainly it's pain that's the problem, but some complain of instability, some complain of crepitus, although there's not much you can do about it. A few complain of weakness, which means probably they've not been rehabbed properly. Some complain of some stiffness, and swelling can go on again for months. Treatment initially is price, protect, rest, ice, compression, elevation, do no harm, heat, alcohol, running, massage. I don't like non-steroidals because I think it affects the normal healing process. There is some research out there saying they probably make the recovery slightly quicker, but unless you're an elite athlete, I think I'd avoid them. Elevation will be very helpful. You can evaluate 5 days. I really want to start operating on these. I can't find any indication to do because I would get them better without an operation. Maybe the very, very elite athletes may get back to their sport quicker, but I think that's controversial. So I don't think there really is any indication for acute surgery. I think those, however, that do have the severe grade, a period of mobilization, 2 to 3 weeks is reasonable in a simple brace or a boot. And that to me is really to prevent re-injury. And the ones that I see that are chronic problems, the ones that have a sprain, then 2 days later do it again, and then 3 days later do it again. And that's never going to allow some healing. So I think, having some form of support or advice that they shouldn't be going to back to the activities until they can do them, I think is reasonable. And then functional rehab over to the physios for the majority. But with this, we got to make sure we get the diagnosis right. We've got to make sure we get the severity right so we can give a prognosis and allow them to have full recovery. But there are other diagnoses, and I'm going to go a little bit into that. First of all, if you look at a foot, I think this goes with a lot of medicine. If something's not right, it usually isn't right. So if someone comes and says they've had an ankle sprain and the foot is enormously swollen and deformed, they've probably not had an ankle sprain. And this is a patient that presented with an ankle sprain, and we met them a few months down the line. They're diabetic neuropathic, but if you don't ask that question, you don't know the answer. And everything was just very, very wrong. And he just said he sprained his ankle. But clearly he's now walking on his tibia, which is not great. So you just need to be aware. If something's wrong, then it needs to be investigated. And you also want to investigate if you're suspicious of a fracture, or if there's an unusual presentation as described, or if the pain is not where you expect it to be. That's when you need to seek help and consider other things. Hopefully most should know about the Ottawa ankle rules. I'm not going to go into them. They're very, very specific in picking up, sensitive in picking up fractures, but very non-specific. So they pick up most of the fractures. So if you stick to that, you're not going to miss many fractures, hopefully. But they don't really pick up where they are, unfortunately. So we talked about the area where the ankle sprain is, which is classically this area right in the middle. If there's pain elsewhere, you've got to think of other diagnoses, and we can go through these, and I'll briefly go through them. If it's on the fibula fracture. If it's deep within ankle joints, you can get these little divots of bone. If it's at the front, you can get, so that's away from where it is, you can get little navicular avulsions or talar avulsions. Around here, which is the anterior area here, anterior process of the calcaneum, that's the most common one I see that's missed. Base of the fifth is probably one of the most common injuries we see, which is down here. Lateral talar process is very difficult. And if you do have pain at the back of the ankle, it's not really going to be likely to be a sprain, and you can get these little breaks at the back around the os trigonum. So with the soft tissue kind of injuries you see, again, you don't want to miss Achilles rupture, squeeze the calf, and if it's attached to the heel, you haven't got an Achilles rupture. You can damage this thing, superficial peroneal nerve, which is one of the ongoing reasons for pain. And a lot of people have a bit of loss of sensation around the top of the foot due to injury to this. It's one of the only nerves you can actually see with just looking at your foot. So it runs along here. This is a rare diagnosis called os peronei, but the peroneal tendons which run around the back can be injured in the same mechanism as ankle sprain. So if the pain is behind the lateral malleolus, you've got to think, is this a peroneal tendon problem? And the reason to pick up these injuries is that the treatment's different. It can be immobilization, surgery, and the recovery may just be longer. And actually, most of the fractures that are missed that I see, most of the most common ones, anterior process of calcaneum, there's nothing to do. Nothing would have made any difference to their recovery. They're just a bit knocked off that the recovery has taken 6 months rather than 2 months, and no one told them why. So that's the most common one I see. But it is partly patient information more than anything else. Just to go a little bit about a high ankle sprain, tibia is attached to the fibula. There's 4 ligaments that go across here. Basically, the one at the front, which is the anterior tibio-fibular ligament, inferior tibia ligament, the one at the back, the posterior inferior tibio-fibular ligament. There's the interosseous ligament that goes across here, and a transverse ligament at the back. This is a very, very stable structure. So injuring this person that you see here is very obvious. They wouldn't be able to walk. So they'd be picked up. But it is quite important to pick it up because this is treated slightly differently. And the injury is slightly different. I talked about ankle sprain being inversion. These are more eversion. So the foot's turned out and they often rotate round the foot. So it's an eversion injury rather than inversion injury. To pick it up, there's these 3 tests that you can do. Basically, if you press over where the syndesmosis, which is around here, and it's painful, you need to consider it. If you then squeeze the tib and fib together, and they have pain around the syndesmosis, which is around here, when you're squeezing it together, then you need to consider it. If you rotate, so externally rotate, that's you hold the leg, you externally rotate the foot, and again, they get pain around the syndesmosis. All three of them being positive, and they need urgent investigation. They're not totally sensitive, but they're all three, I think, is pretty good at picking it up. And the reason why you pick up some of these is that some of them need surgery. So this is a tightrope, and I scope them, clear it up, and then put this tightrope across, and they seem to do pretty well. And mainly because if they don't do it, they do pretty badly. So this is more of interest about the ones that aren't getting better. So if you're not getting better, my question always is, have we got the diagnosis right? Now, it may still be a simple ankle sprain. It may be that, and they may not got better purely from that. But I think it's their duty bound to investigate at that point. So I always question the diagnosis, always question my diagnosis, then I investigate. So the reasons why people don't get better, it can be simply just they've had an ankle sprain and it hasn't got better. So they can be left sometimes with some scarring behind the ligament, and they get something called anterolateral impingement, which is basically where some soft tissue gets caught within the joint. It can aggravate a existing condition. I'm sure everyone has seen someone with significant knee arthritis, if not ankle arthritis, that has a minor fall, and they blame the minor fall on their ongoing pain. And all they've done is aggravate what is a condition that's been there. So it can be aggravating existing conditions such as ankle arthritis. We can miss a fracture, so it's not that uncommon with anterior process calcaneum, because I think it's really difficult to pick up on your x-rays unless you've got an oblique of the ankle, of the oblique of the foot, and it may be an undiagnosed tendon injury. I'd say they can be quite difficult to pick up. So initially you investigate suspicion of a fracture or the presentation severe or pain in the wrong place. If you want to, down the line, if they're not getting better after 3 months, their failure to improve or they failed initial management, that's the indication for me to investigate. And I'm not going to go through this slide again. It's just going through the different diagnoses that it can be, which go all the way around, and the different soft tissue diagnoses it can be. But there's some add-on ones such as ankle arthritis or ankle impingement, which is basically the bones at the front of the ankle just knock against each other when they move. But there are other more unusual diagnoses such as stress fractures or ganglions or even midfoot arthritis that's been flared up. And then depending on the foot shape, you can get a pain around the lateral aspect, which can be impingement, and you can get ongoing problems from the sprain itself, which is usually anterolateral impingement. And then looking at the back, there's something called posterior impingement, again, the knocking of two bones together at the back of the ankle. Usually it's an os trigonum as well, or Achilles problems. And the reason why you've got to make that diagnosis is because you have a whole different modality, lots of treatment and investigations. Tendons are best picked up by ultrasound, although mostly I'll be doing an MRI scan to screen them, and I'll discuss that in a minute. Some of these other ones, this lovely image of this bright yellow is a SPECT CT, which can pick up undiagnosed fractures, and very good at picking up arthritis, certainly across most of the foot. And CTs can sometimes be helpful, but they're not always that great. So the reason why we make that diagnosis, the treatment options, start off with physiotherapy, injections can be helpful. We can do arthroscopy, so keyhole surgery, try and clear it up, to try and clear up any of the abnormalities. We can fix fractures if needs be, repair tendons, which is usually an open procedure, or simply go on to bracing. Finally, I'm going to mention instability very briefly. So ankle instability is basically split into two varieties. There's true instability where the ligaments don't work, and there's instability where you basically get pain. You get inhibition of the muscles around and your ankle goes over. So the true instability, you can be walking and you just go over on it. The mechanical instability usually is you get some form of impingement, so some form of pinching of bone or soft tissue, which causes pain, and then they go over on it. So it's two very different things, although you can have both, clearly. And if you're going over on it regularly, because it's true instability, you're going to end up with some form of pain as well. So mainly mechanical instability, so the one which is the ligament being long and defunctioned is painless, and functional instability is one that's pain and then you go over. It can be a combination. To really delineate, I've got this little video here, which is an anterior draw test. I hope you can see that. And basically, this is the inside of the ankle here. This is the outside of the ankle. Unfortunately, that's my hand. And we're just stressing the ankle. And if you can just see here, that comes forward. And actually, the next view, if you see that when it comes forward, a sulcus appears, and that sulcus is abnormal. And they've got a defunctioned ankle. Now, interesting enough, you can find that, and I find it all the time on people without any problems at all, without any instability. So it can be an incidental finding. But if someone is complaining of true instability, it needs to be examined. And if that's the finding, then yes, they may have true instability. Ooh, let's go off that. So just a little bit, some of the treatments that we can provide. For those that have ongoing pain secondary to a simple sprain, the most common diagnosis is this very angry red tissue that appears at the front. And again, where the ankle, where you sprain the ankle, where ATFL is, you can get some scarring and some inflammation behind it, which basically looks red and horrible like that. And they can impinge there. And we can treat this often by an injection that can resolve it. If injection doesn't work, we can clear it up via an arthroscopy. But to be honest, I'm getting such good results from injections that I'm not doing this. I love doing it, not doing it as much as I'd like to. And for those that have true instability, the gold standard is something called a Brostrom Gould. And basically, we just shorten the ligaments. Now, people worry a lot about the ligaments not working and not being there. To be honest, a rupture, a complete rupture, will always heal. I don't think I've ever seen it not heal. The question is whether it heals long. So whether it heals long or whether it heals the right length. And that's why in the complete ruptures, I do a period of conservative management in a boot so that it can heal at the right length and they don't go over on it. So all we do in the Brostrom Gould, which is the operation that everyone I think does in my position, we just shorten that ligament. So we take it off its insertion and then tighten it up. We do add the extensor retinaculum as well, but that's basically all we do. So in some of your ankle sprains, you want to get the correct diagnosis. Use the Ottawa ankle rules to make sure there's no fracture and refer any unusual presentation or severe or pain in the wrong place or Achilles ruptures. Try and pick up the ankle sprains and the high ankle sprains and refer them up. And if they're not getting better with conservative management and they have ongoing pain and instability, then please we'll have a look at them. In terms of investigations, again, weight-bearing x-rays, that'll just be repeated if you don't do them. And I would get x-rays. I think they're very important and often very useful in picking up the shape of the foot, which can be very fundamental in treating some of these, certainly if you could consider surgery. And they will pick up arthritis and impingement, certainly bony impingement, better than the scan is. But also an MRI scan, I think, is a very good screening tool for these. And I'd happy if you get both of these before they come and see us, because I think it's very useful. The final thing I'm going to mention is just a midfoot sprain, because this is something called a plantar ecchymosis sign, which is bruising underneath the foot. And the anatomy here, which I'm not going to go into, the midfoot is a very stable structure, and any form of disruption of any of the ligaments or bone there can cause significant problem. There's a Lisfranc ligament that goes from the medial cuneiform to the base of the second. It's got 3 components to it. It's extremely strong. And if that then basically fails, the foot is not really attached to the rest of the midfoot is not really attached to the rest of the foot. So they can develop arthritis very quickly. So there is no such thing as a midfoot sprain. Well, there is, but it's a diagnosis that only very few should make. So please refer up. And the reason why you should refer up is that if the position of the foot is in the right position, the bones are in the right position, they do well. That's all this graph shows. And if the bone is not in the right position, they do badly. And that's summary. So 80% do well when you correct it, and 80% do badly if you don't. So that's a plea that there is no such thing as a midfoot sprain. They should be sent off. And this is classically what you see. And there's nothing massive to see. This is the medial cuneiform, the base of the first metatarsal. So that's this bit here on a CT scan. And there's just widening between these two, indicating a ligament injury here. And I've just replaced the ligament with a screw, which just holds it there while the ligament heals. That screw can come out or can break, it doesn't really matter. And this is a much more severe one where you can see all this foot is basically dislocated off the rest of the foot. So there's a widening of here. This is dislocated off here, sorry. This is dislocated off here. They're all in the wrong position, and we've had to fix this quite rigidly. So again, just to go back into, so that's most of it done. So if you go back into my role, you know, I'm there to make the diagnosis, investigate, give prognosis, and select appropriate treatment, surgery only at the end. And I think, as I say, I think foot and ankle is a difficult subject. You know, something that I think we all find that was difficult through training. I mean, I love it. I think it's brilliant, but it's it's not classically taught very well. And if you have any questions about the diagnosis, we'll happily see whoever you want to. It's certainly not only refer people that need surgery. We're happy to talk through anything or investigate anyone so that they can know if it's simply just the diagnosis. But if you're able to make the diagnosis, then we're very happy to see them when they've had their initial investigations and treatments. Achilles tendon, obviously get the right diagnosis, insertional versus non-insertional. I think we need to have at least 3 months of conservative treatment before we can consider anything further. And non-insertional Achilles enthopathy, just to repeat, X-rays are important, but MRI, ultrasound is the next step. Insertional Achilles enthopathy, X-rays again important, and MRI to me is the modality of treatment that I'd choose. And obviously, there's a shared decision-making treatment after that. Finally, looking at bunions, referral criteria need to be completed before we can opt for surgery. So if you can do this, this would be great. And obviously they need to undergo conservative management, willing to undergo surgery, understand what it's about. They've failed at conservative management, or they've got severe deformity or problems with the second toe. And that's really where, that's when they should be referred up to consider surgery. They're not all going to get it, but certainly to talk it through. Investigations, you need X-rays, and please don't organise ultrasounds in the presence of toe deformity or callosities, because you will find a neuroma, but that's not their problem. So finally, ankle sprain, try and get the diagnosis correct. It can be quite difficult. Stick to the L2 ankle rules. Unusual presentation, severe, pain in the wrong place, Achilles rupture. Try and diagnose the high ankle sprains, and obviously those that fail conservative management or have ongoing problems of pain or instability, we'd very happily see. Thank you very much. This is just a quote. I always think the foot is an amazing structure, and I'm surprised it doesn't break down more often, considering the forces that go through it. So the foot's at a lever arm, so the foot, the big toe, has 4 to 6 times your body weight going through it as you run, and how that toe can manage, I don't know, but it's amazing how it doesn't break down. So I think the foot is absolutely incredible. Thank you very much.
Thank you, Mr. Hamilton. There are a couple of questions in our question and answer session. So Rachel, I think
you'll be here, you can hear me.
Yes.
Can you hear that? Hopefully everyone can hear that, yeah.
So Rachel has asked, what advice do you give a higher level rugby player who has sprained their ankle and is requesting an MRI to determine if surgery is needed?
That's a good question. So surgery is very rarely needed. Those that are very high level, sometimes it's worth getting the exact injury just to give them a prognosis, so that you know their recovery, so that you can give them an idea of when they're going to go back to their sport. So that's a whole different management. We can't MRI everyone that's had a sprain. So those that play at a professional level, it's so you know they can. The other example is those with a calf tear. You know, a calf tear doesn't need any form of investigation at all. But those that are a high-level athlete will have investigation, so they can grade the calf test, so that they can tell the manager when they're going to play again. So I think that is, I have no problems with MRI scans, but we can't MRI everyone. And for those that have had a simple sprain that get better very quickly, they do not need an MRI scan, in my view. Does that make sense?
Perfect. So Harriet has said, hello, I'm a first contact practitioner physio. I ruptured my ATFL last weekend, so was looking forward to this presentation. I've been given a boot. Is it useful for avoiding injury or beneficial to healing as well? Now realizing why patients struggle with compliance.
So there's 2 bits to that. There's, it's re-injury that I really worry about, to be honest. So it depends on your grade. So if you've got significant swelling and the swelling is just on the outside, because if there's swelling on the inside and outside, that puts up the level of grade quite significantly. So just swelling around ATFL, and the swelling is reasonably small, then a boot is not totally necessary, but you don't want to re-injure it. If you are going to wear a boot, it's only for 2 to 3 weeks. You can wear a brace when you start doing activities after that, but you don't want to rely on that. So the answer is, for me, it's mainly about re-injury. But if you've got a severe sprain where it's definitely ruptured, then I would say 2 to 3 weeks to allow it to heal the right length is also a reasonable thing to opt for. Did that answer your question? I hope.
She said inside and out, she heard and felt the snap.
So inside's on the medial side as well. So the snap means you probably have ruptured it. Yeah, I'd wear a boot for 2 to 3 weeks, definitely.
I think that might be all the questions we've got. Are there any other questions? You can post in the question and answers or the chat function.
Could they not come on and actually talk?
No, I haven't worked out how to do it yet. Probably. Maybe next time we can work it out. Well, if there aren't any other questions, thank you very much for joining us. We do have a couple more foot and ankle presentations this month, so look out for those invitations. And we will send you a feedback form that we'd really appreciate it if you could fill that in for us, as well as send you your CPD certificate, attendance certificate for your portfolio. So if there's no other questions, thank you everyone, and we hope that you have an absolutely lovely evening.
Thanks very much. Thanks all.
Bye-bye.